This is a video in clinical medicine from the New England Journal of Medicine.
Femoral venous catheterization is a rapid way to obtain intravenous access in hospitalized or emergency department patients. In this video, you'll learn how to safely place a femoral line. Placement of a femoral line may be indicated in the following situations: to obtain vascular access when peripheral access cannot be accomplished, to administer hemodialysis when access at a preferable site is not an option, to perform cardiac catheterization, or to administer large or caustic infusions. The following situations are relative contraindications: an uncooperative patient, the presence of infection, trauma, or distorted anatomy at the insertion site, obesity if it will significantly impair your ability to find the femoral vein, coagulopathy, and operator inexperience or lack of supervision. Femoral venous catheters, especially if left in place for more than a few days, are associated with an increased risk of infection and thrombosis as compared with subclavian and jugular lines. Therefore, if there is a safer insertion site, avoid performing femoral venous catheterization. When possible, explain the procedure to the patient and obtain informed consent before placing the catheter. In accordance with your institution's regulations and policies, go through your checklist and verify the patient's identity, check for contraindications, and then verify the procedure and site. A colleague should assist you with this process. Gather the necessary equipment. You will need intravenous fluid and tubing, additional anesthetic, a central venous catheter kit, and blood drawing equipment. You will also need a cap, face shield, sterile gown, and gloves. The basic components of a central venous catheter kit include chlorhexidine skin prep, a sterile drape and several pieces of gauze, ampules of lidocaine and saline, temporary and permanent sharps disposal cups, a syringe and small-gauge safety needle for administering local anesthetic, a larger introducer needle for identifying the target vessel, a guide wire, a scalpel, a dilator, and a central venous catheter. Notice that each port on this triple lumen catheter is color-coded. The most distal port is brown. For securing the catheter, you will need either staples or sutures on a curved needle and a needle driver. A transparent adhesive dressing is needed to cover the insertion site. Review the anatomy shown here on a cadaver. The position of the femoral nerve, artery, and vein from lateral to medial can be remembered with the mnemonic navel, or nerve, artery, vein, empty space, and lymphatics, pointing to the navel in that order. The femoral vein can be found 2 centimeters beneath the inguinal ligament and 1 centimeter or approximately 1 finger breadth medial to the femoral artery pulsation. In a pulseless patient, you can approximate the location of the vein by placing your thumb over the pubic tubercle and your index finger over the anterior superior iliac spine. The vessels should lie within the web space. The head of the bed should be flat to minimize any flexion at the hip. Abduct the patient's leg away from the midline and externally rotate the hip. Assess the site with ultrasound whenever possible to confirm that the vein does not lie directly over or under the artery. This is the bifurcation of the femoral artery, and medial to it is the vein, which collapses when compressed. Before getting sterile, wash and sanitize your hands, and open the central line kit. Then, in a sterile fashion, mask, cap, gown, and glove yourself. Appropriate sterile technique has been shown to significantly decrease infectious complications. Prepare the central line kit. Add sterile saline for the line flush, as well as extra anesthetic. Draw several milliliters of saline into a syringe and flush the catheter ports. Remove the cap from the distal port to allow the wire to pass during the final step of catheter placement. Test the seal between the needle and the syringe. The needle should detach easily. Adjust the wire so that the end is straight. Next, prepare the skin by applying chlorhexidine to the femoral region, using a much larger area than you would expect to need. Allow the skin to dry for at least 30 seconds, then drape the patient and place the wire on the sterile drape. Now, anesthetize the region. The amount of 1% lidocaine provided in standard kits is often too little and too short-acting. Obtain additional lidocaine with epinephrine or bupivacaine, both of which last about 2 to 4 hours. Use a syringe and a 25-gauge or smaller needle to deliver the anesthetic. Alternatively, you may use a longer, small-gauge finder needle to anesthetize deeper tissues. Test the site to confirm that the region has been properly anesthetized. Adequate analgesia will increase your patient's comfort and your chance of success. Several studies have shown that using ultrasound to assist in the placement of a central line increases success and reduces patient complications. This animation demonstrates how to scan the femoral region and accurately locate the femoral vein. The ultrasound screen shows a cross-section of the femoral vessels. Objects close to the probe appear at the top of the screen, whereas objects far from the probe appear at the bottom. Notice that the probe has a mark on one side. This index marker corresponds to the green dot on the monitor. Choose a linear, high-frequency probe for best resolution. Begin by covering the ultrasound probe with a sterile sleeve as shown. Apply gel to the inside and outside of the protective covering. Make certain to use a sterile gel on the outside. The ultrasound monitor should be facing you and placed to the side of the patient where you are standing. Position the probe with the orientation mark to the patient's right. Notice now that your left also corresponds to the left of the monitor. This is the artery, which is pulsating, and just medial to it is the vein, which collapses when compressed. Position the probe so that the vein is in the center of the screen. Insert the needle at the center of the probe and watch the monitor to see the needle pierce the vein. Once you see a flash of blood, take the ultrasound probe off the patient and continue with the procedure. The modified Seldinger technique minimizes the risks associated with intravenous catheter placement by locating the vessel with a needle and introducing a guide wire into the vessel lumen. There are 5 steps to proper technique. First, find the vein with the introducer needle. You will know when you are in the vein when non-pulsatile venous blood is identified. Second, advance the guide wire into the vessel lumen. Third, withdraw the needle and use a scalpel to cut the skin adjacent to the wire. Fourth, dilate a tract from the level of the skin into the vessel lumen. Fifth, advance the catheter over the guide wire into the vessel, while maintaining control of the guide wire at all times. When not using ultrasound, palpate the artery and insert the introducer needle at a 45-degree angle from the skin while aspirating with the plunger. To avoid an arterial stick, know where the artery is by maintaining palpation of the arterial pulse whenever you are advancing the needle. Now stabilize the needle with your other hand. This is the most common time for the needle to dislodge from the vein. Preserve the exact angle and depth of the needle by resting your hand on the patient. Detach the syringe with a twisting motion and thread the wire, holding the wire at all times. Remove the needle and use the scalpel to nick the skin at the site where the wire enters the body. Hold the scalpel so that the sharp end of the blade is away from the wire. Use the dilator to make a tract through the tissues. Hold it close to the skin and use a twisting motion to advance the dilator. There is often heavy bleeding from the insertion site after the dilator is removed, so be prepared to hold pressure with some gauze. Remove the dilator and thread the catheter onto the wire. Hold the wire at the skin while sliding the catheter forward. Do not let the catheter pass through the skin until the wire has passed out of the distal catheter port and you have grasped it firmly. Remember, do not let go of the wire. After you have threaded the catheter, remove the wire, aspirate blood from each port, and flush with saline or heparinized saline. Now that the catheter is in place, secure the catheter using the suture material or staples found in the kit. Be sure that the patient knows you are going to be securing the line. Confirm local anesthesia and provide additional anesthetic if necessary. Staples are more convenient and decrease the risk of needle sticks, but may not secure the catheter as well as sutures. When you have finished, apply a sterile, transparent, occlusive dressing over the site. If there is good flow on initial aspiration, and the wire does not pass through the needle, remove the wire and reconfirm flow into the syringe. If you are unable to reaspirate blood into the syringe, it's possible that the needle has been advanced through or pulled back out of the vein. Adjusting the depth of the needle until blood can be aspirated will allow proper positioning of the needle for readvancement of the wire. If the wire will not pass despite good blood flow, flattening the angle of entry or twisting the wire in your fingers to change the direction of the distal end may allow passage of the wire. Never force the wire against resistance. It may be kinked or extraluminal. Femoral venous catheterization is not a risk-free procedure. The following are possible complications: infection, hematoma, arterial puncture, fistula, pseudoaneurysm, and catheter embolization. You may be able to prevent the development of a hematoma by reducing the number of attempts and applying pressure after withdrawal of the needle or catheter. If you puncture an artery, apply pressure to the site for at least 10 minutes. Infection risk can be minimized by applying a sterile dressing, reducing manipulation of the line, accessing the line under sterile or clean conditions, and removing the line as promptly as possible. After you have finished, be sure that all sharps have been removed from the patient's bedside and placed in a sharps container. Deposit the remaining trash in an appropriate receptacle.